Dermatology. Structure of the skin. Skin is composed of three layers: epidermis, dermis, and hypodermis. Epidermis is the outermost layer of the skin. It rests on basement membrane. It's formed of closely packed cells, keratinocytes, main cells of the epidermis, melanocytes, and Langerhans cells. Keratinocytes, their function include keeping skin integrity impermeable, production of covering protein layer, keratin, and secretion of different cytokines. They are arranged in the following order: proximal to distal. Basal cell layer, resting on the basement membrane. It is a proliferating layer formed of actively dividing cell for renewal of the epidermis. Squamous or prickle cell layer, distal to the basal cell layer. Granular cell layer. Cells contain keratohyalin granules and keratin precursors. Horny cell layer, outermost layer, composed of dead keratinocytes with no nuclei. Melanocytes, for formation of melanin, the skin color contributor. Langerhans cells for immune defense of the skin. Dermis. It is proximal to basement membrane. It's composed of collagen fibers, elastic fibers, matrix of glycosaminoglycans with blood vessels, lymphatics, nerve fibers, nerve endings, skin appendages except nails, which are not in the dermis. Subcutaneous tissue. This is composed of lobules of fat cells separated by fibrous septa composed of collagen and large blood vessels. Skin appendages. Nails contain hard keratin. Hair follicles produce hair shafts, which are composed of hard keratin. Sebaceous glands discharge their sebum content into hair follicles by the action of erector pili muscles. Together with the hairs, they form the pilosebaceous units. Sweat glands. Eccrine sweat glands open on the surface of the epidermis through sweat ducts all over the body surface. Epicrine sweat glands discharge through the pilosebaceous ducts. They are present in body flexures, areola, genitalia, and eyelids. Absence of hair follicles is called alopecia. Absence of melanocytes is called vitiligo. Functions of the skin: protection against physical injury, prevention of water and electrolyte loss, excretion of sweat, temperature control, sensory function like temperature, pain, pressure, and touch, formation of vitamin D, immunological function, and psychological function for communication between individuals. Cutaneous signs. Primary lesions. These are initial lesions of skin diseases which differ from one disease to the other. Macule and patch. Flat circumscribed non-palpable area of skin discoloration. If less than 1 cm, it's a macule. If more than 1 cm, it's a patch. Both can be hypopigmented or hyperpigmented or red or other colors. Then we have papule and plaque. Both are circumscribed solid elevation of the skin. If less than 1 cm, it's a papule. If more than 1 cm, it's a plaque. And the elevation may be due to increased thickness of the epidermis and or cells or deposits within the dermis. It can be of various shapes, such as rounded, polygonal, pointed, flattened, dome-shaped, or various colors, such as skin-colored, erythematous, or violaceous. They can also be covered by scales. Then we have vesicles and bulla. Vesicles and bulla are circumscribed elevation of the skin containing clear fluid. If less than 1 cm, it's a vesicle. If more than 1 cm, it's a bulla. Pustule, circumscribed elevation of the skin, less than 1 cm, but it's filled primarily with purulent fluid, and it's a secondary lesion due to secondary infection of a vesicle, as in impetigo contagiosum. Wheal, it's the primary lesion of urticaria, transient, edematous, erythematous, skin-colored elevation of the skin of variable sizes. Nodule, circumscribed solid elevation of the skin, more than 1 cm in diameter, but with deep component involving dermis and subcutis. Greatest mass may be beneath the skin surface. Comedo, the primary region of acne. Keratinous impaction within follicular canal with open orifice, such as open comedo or blackhead, or closed orifice, closed comedo or whitehead. Beru, primary region of scabies. Linear elevation underneath the stratum corneum digged by the female Sarcoptes scabi mites. Secondary lesions, they occur as a result of modification of primary lesions due to trauma, scratching, topical applications, secondary infection, oozing, and dryness. Crust, dried material of serum, blood, pus on the skin surface. Scale, accumulation of keratin due to increased proliferation or decreased desquamation of stratum corneum. Fissure, linear cleft through the epidermis extending into the dermis. Usually it's painful and results from marked drying, skin thickening, and loss of elasticity. Erosion, partial loss of epidermis or epithelium not reaching deeper layers, heals without scar. while the ulcer heals leaving a scar because it involves full thickness loss of epidermis or epithelium plus deeper layers. Excoriation, superficial discontinuation of the epidermis due to injury, most likely scratching by fingernails. Atrophy, it may be epidermal or dermal. If dermal, it's due to loss of collagen fibers or elastic fibers leading to depression, while if epidermal atrophy, it's due to thinning of the epidermis leading to shiny appearance and wrinkling. Lichenification, increased epidermal thickness with accentuation of natural skin line. Skin infections, bacterial infections, impetigo, superficial infection of the skin. Etiology, streptococci or staphylococci. Infection could be primarily predisposed by poor hygiene or moisture, or secondary complicating insect bites, scabies, pediculus capitis, or viral infections or eczema. Clinical types, we have impetigo contagiosum, bullous impetigo, circinate impetigo, ulcerative impetigo. Impetigo contagiosum, the disease begins with erythema, primary lesion, vesicle, rapidly develops, turns into pustule, rupture, oozing, seropurulent discharge, dry from golden to form golden yellow crusts. It occurs on the face, hands, genitalia, scalp. There are no constitutional symptoms and resolves within few days. Bullous impetigo, 4S, staphylococci, primary lesion is bulla, occurs at any age, characteristically occurs in newborns and infants, children. In newborns, it's usually accompanied by constitutional symptoms and it may end fatally. The 4S are staphylococci, scaled skin syndrome. Circinate impetigo, it occurs as an extension of impetigo contagiosum or secondary to rupture of bullous impetigo with annular fistone blisters. Ulcerative impetigo or eczema, it's usually on the legs. Lesions have thick crusts which heal, leaving scars. Complications, spread of infection to other sites, spread of infection to other patients, or post-streptococcal glomerulonephritis in 2 to 5% of the cases infected by nephrogenic strains. Management, health education, washing hands with soap and water, control of the predisposing factors, total antiseptics such as potassium permanganate 1/8,000 to 1/10,000 solution, topical antibiotics, mupirocin cream and fusidic acid cream, systemic antibiotics given if infection is generalized, associated with fever and lymphadenopathy, or in immunocompromised patients, or in cases of bullous impetigo or eczema. Folliculitis or impetigo of Burkhardt, infection of the upper part of the hair follicle due to Staphylococcus aureus infection. Predisposing factors are moisture, poor hygiene, shaving with infected instruments, and ingrowing hairs. Clinical picture, follicular pustules and papules. Management, topical antiseptics, topical antibiotics, control predisposing factors, and systemic antibiotics. Furuncle or boil, deep infection of the lower part of the hair follicle with central necrosis. Predisposing factors, obesity, diabetes mellitus, but it may occur in healthy individuals. Clinical picture, follicular red tender papules that enlarge with central pustulation, necrosis in the center, and heals within few days. Management, avoid predisposing factor, topical antiseptics, topical antibiotics, systemic antibiotics. But before we go to the new part, we need to know if the infection occurs in the lower part of the hair follicle, then it's a furuncle or boil. But if in the upper part of the hair follicle, it's called folliculitis or impetigo of Burkhardt. Okay? Then we're gonna go to carbuncle, multiple coalescent deep boils which open on the surface by multiple openings. Predisposing factors, immunocompromised patients and diabetes mellitus. Clinical picture, deep indurated erythematous tender plaque with multiple opening, oozing pus. It occurs on the back, neck, and intertriginous areas. Management, incision and drainage with systemic antibiotics. Erysipelas, suppurative inflammation of the upper dermis. due to infection by beta hemolytic streptococci, predisposing factors, lymphedema, clinical picture, common on the lower limbs or face. Erythematous, swollen, tender area with sharp border. In extensive cases, blisters may be formed. Constitutional symptoms including malaise, fever, and rigors, and it tends to recur. Complications: lymphedema occurs from recurrent episodes and glomerulonephritis. Treatment: systemic antibiotics as penicillin or erythromycin. Cellulitis: suppurative inflammation of the lower derms and subcutaneous tissue. Streptococcus pyogenes. Clinical picture: erythematous swollen tender area with an ill-defined border. Constitutional symptoms such as malaise, chills, and fever. Treatment: aggressive antibiotic therapy. But before we go to the new part, we need to compare between erysipelas and cellulitis. Erysipelas is suppurative inflammation of upper derms, while cellulitis is suppurative inflammation of the lower derms. Erysipelas have the same clinical picture, swollen tender erythematous area but with sharp border, while cellulitis has ill-defined border. Both have constitutional symptoms such as malaise, chills, fever, and rigors, and we're gonna add in erysipelas recurrence with lymphedema and glomerulonephritis. Both are treated by systemic antibiotics, aggressive antibiotic therapy, and the etiology in erysipelas is beta hemolytic streptococci, while in cellulitis is streptococcus pyogenes. Then we have erythrasma, superficial infection of the intertriginous areas by Cranio-Bacterium minitissimum. Predisposing factors are obesity, diabetes mellitus, debilitating diseases. Clinical picture is dry, scaly, reddish-brown patches with fine scales in the intertriginous areas such as the axilla, groin, submammary region. Wood slide show coral red fluorescence due to porphyrin. Treatment: topical therapy, antiseptic soaps, antibiotics as fusidic acid, antifungals as azole derivatives, although it's diphtheroid bacteria. Systemic therapy, antibiotics as erythromycin. And finally, we have in bacterial infections, leprosy. Chronic granulomatous myobacterial infectious disease occurs more in tropical and subtropical areas such as Africa, Brazil, and India. Usually targets skin and nerves, but infection may extend to other organs, and it runs a very slow course. Etiology: Mycobacterium leprae, slightly curved bacillus, surface is covered by glycolipid layer, acid and alcohol fast, stained by modified Zell-Nielsen stain, doesn't grow in vitro, but grows in foot pads of laboratory animals. Incubation period long, ranging from 2 to 12 years. Pathogenesis: infection occurs through nasal mucosa by droplet or through wands. Expression of disease depends on cell-mediated immunity. Bacilli enters through nasal mucosa engulfed by Schwann cells. Clinical manifestations occur according to the immune status of the body. Classification of leprosy: we have clinical classification, bacteriological classification, and clinical bacteriological classification. Clinical classification: tuberculoid leprosy reflects high immunity, borderline leprosy, borderline lepromatous leprosy, and lepromatous leprosy, reflecting lowest immunity. Bacteriological classification: Pucci-bacillary leprosy in patients with high immunity and few bacilli, multibacillary leprosy in patients with poor immunity and numerous bacilli. Clinico-bacteriological classification: Pucci-bacillary leprosy and multibacillary leprosy. Nerve involvement in leprosy: it involves superficial nerves such as ulnar, lateral popliteal, greater auricular nerves. Involved nerves are thickened, beaded, and tender. Sensory nerves involvement lead to glove and stock anesthesia with loss of pain, leading to repeated injuries of the hand and feet and trophic ulcers. Motor nerves involvement cause facial palsy, claw hand ulnar nerve, and ape hand medial nerve, dropped foot lateral popliteal nerve. Diagnosis: clinical picture, slit skin smear, skin biopsy, nerve sheath biopsy, polymerase chain reaction PCR, and lepromine test. The slit skin smear from ear lobes, elbows, knees, and any visible lesion, then stained with modified Zell-Nielsen stain. Lepromine test is prognostic but not diagnostic and not specific. Reactions in leprosy: this indicate change in the immune status of patient, either upgrading or downgrading. They appear as acute episodes which occur during chronic course of the disease. They may occur spontaneously or precipitated by treatment, infection, physical stress, injury, operations, pregnancy, parturition, or vaccination. Then we have comparison between tuberculoid leprosy and lepromatous leprosy. Tuberculoid leprosy involves nerves and skin, good immunity. Lepromine test is strongly positive. Bacteriology show no bacilli or pussibacillary. Clinical pictures show maculoanesthetic patch with hypopigmented center. Skin is dry, hairless, and insensitive, plus or minus trophic ulcers. The nerves, they are involved early, may lead to glove and stocking anesthesia. No mucous membrane affections, and no others. Lepromatous leprosy, the involved organs are nerves, skin, and other organs. Absent immunity, lepromine test is negative. Bacteriology show multibacillary. The clinical picture, glistening erythematous or skin-colored papules, nodules, and plaques. Ears are thickened and nodular. Thickening of ears, face, and skin of forehead, plus nodules on nose, and deepening of natural lines give the picture of leonine feces. Eyebrows, alopecia of the outer one-third, legs, edema, plus or minus ulceration. Nerves, late anesthesia leading to loss of temperature, light touch, pain, and finally deep touch, leading to trophic ulcers. Mucous membranes, spontaneous bleeding from the nose, nodules and ulcers from nasal septum. Cartilage destruction leading to nose deformity. Others, eyes, lymph nodes, larynx, bones, muscles and testes. Intercurrent infections. Then we're gonna talk about borderline leprosy. According to patient's immunity, it can be borderline or lepromatous leprosy. Patient exhibits clinical features of tuberculous leprosy or leproid leprosy, and often with prevalence of either one over the other. Treatment, general lines, health care, patient and family education, rehabilitation, management of ulcers. Chemotherapy, multi-drug therapy is administered to avoid resistance of bacilli. Rifampicin to make the patient non-infectious. Dapsone, cheapest and the most important drug. Clofazimine is bacteriostatic and anti-inflammatory. Treatment of pussibacillary leprosy, rifampicin, 600 mg every month, dapsone, 100 mg daily, given for at least 6 months. Follow-up is 2 years after the end of therapy. Treatment of multibacillary leprosy, rifampicin, 600 mg, and clofazimine, 300 mg every month. Dapsone, 100 mg, and clofazimine, 50 mg daily, given for at least 2 years, and follow-up is 5 years after end of therapy.